Thank you, Dr. Amit, for having me here. As we are late, I would just wind up the talk with a few points and a summary to close it off. So the topic is about angle closure disease and its management. At the outset, we would welcome you all to Mumbai and hope you are having a good time. So, as we know, we have classification of angle closure into primary and secondary angle closure, which is pretty basic and we all know about it. I will be just going through the very salient points because we don't have time. And it's in a population-based study with esteemed faculty that we have here. They have done it themselves. It's around 0.5 to 1.9% of the population. Blindness, though, is carrying a threefold higher risk than that of open-angle glaucoma. The important thing that we should know is iridotrabecular contact in any form compromises the meshwork function, and there is no way to know how much of meshwork function is compromised, and changes in outflow facility manifest as IOP spikes, larger DVs that need to be picked up early. Chronic PACGIs progressed earlier and faster according to studies by our own teacher Ciota et al. And they progress much faster than open angle glaucomas. We have the common ISGO study staging of the disease, where we know that it's a more practical explanation of the angle structures, which is divided into PACS, PAC, PACG and acute episode of angle closure attack. This explains the prognosis and the management better, whereas the age-old classification of glaucoma explains the symptomatology and clinical findings better. That is the angle closure suspect, acute angle closure, intermittent, chronic and status post-acute attack. Now the symptoms we all know, symptomatic angle closure is always an acute angle closure. Otherwise, it's basically asymptomatic disease manifest with repeated blurred vision and changes in refraction. And status post-acute attack, we can see some things like flecken, pupil abnormalities and disc pallor. Now, important thing is pupillary block is the most important theory according to Mapstone and constitutes 75% of the cases, and the rest are due to the ciliary body abnormalities, lens-induced abnormalities behind the lens, and they are precipitated by dim light accommodation, stress, dilatation of the pupil, etc. There can be more than one mechanism at play at one time. That is what we should know. Investigations of glaucoma are pretty common, but remember that gonioscopy is the holy grail, and more so in case of angle closure disease. Apart from that, a point about provocative test, it's historical with no role, and they put the patient at the risk of angle closure in predisposed eyes, and the sensitivity is poor. OCT angiography does give us a nugget of information which I shall just show you. And ASOCT and UBM are in specific situations like plateau iris, cysts, malignant glaucoma, drug-induced. We can use them on a per-case basis. Gonioscopy is the cornerstone. We know all how important gonioscopy is. Knowing the importance of the corneal wedge, indentation gonioscopy is very, very important. What we should always know that on every follow-up, we should document meshwork progression, inter-eye asymmetry, and new areas of pass. That is what we call as gonio progression, which people don't talk about as commonly as progression in the fields and perimetry and OCT. Pigmented Schwalbe's line is one of the common sources of error. So use indentation and corneal wedge to identify it so that that mistake is avoided. Variations in pigmentation in single eye also occur. Temporal and nasal angles are pretty tricky to identify because of the difficulty in getting a corneal wedge there. But always remember that pigmentation over the angle should be closely documented, and blotchy pigmentation is a telltale sign of iridotrabecular contact. Now, which angles stay closed is very important, because after PI we feel that all angles open, but there are certain angles with thicker iris insertion, thicker iris itself, plateau iris, large lens and smaller anterior segment, and all iridotomies do not open a narrow angle. The primary role is to prevent pupillary block. That is something that we should always remember. After these studies with the UBM and ASOCT, many things of these were clear, and you know that now the iris can be inserted in various ways. It has various configurations, various thickness, and there are some things called as relative anterior microophthalmos, and all these cases have their own implications in angle closure and the role of iridotomy. Lens wall, anterior segment biometry and iris patterns, and also ciliary body and iris imaging have thrown light on various mechanisms of angle closure that can be refractory to iridotomy opening the angle. OCT angiography and macular ganglion cell complex have thrown up interesting findings about angle closure disease because they cause acute ischemia. The amount of capillary dropout that occurs suddenly after an acute pressure elevation is something which we found out, which we had presented in one of the 2 meets of the GSI, and immediately post-operatively, you can't find that out on clinical examination. The disc pallor sets in late, but the changes on the ganglion cells are pretty immediate, and you could find that out as early as 2 to 3 weeks post acute attack. That is something we should keep in mind. Something like this, when the disc appears pale, the RNFL is still decaying, but the field is like this. Such cases cannot be explained by anything except the loss of the RPCs, which is very acute following a acute elevation of intraocular pressure. So a nugget about these new investigations. Similarly, here also you can see acute elevation of IOP. Everything else appears okay except the loss of the macular ganglion cells in the superior part. One more case which shows the same finding here. RNFL relatively preserved better than the ganglion cell complex after an acute elevation of IOP. Field defects vary in angle closure disease because of the ischemic damage. There is no pattern in acute angle closure, but definitely chronic angle closure mimics open angle glaucoma. So we find the whole gamut of changes, and that will depend upon the pathophysiology of IOP variation. So it depends on duration of pressure elevation and can manifest also in a few months. Misdiagnosis of PACG is common. The expertise in gonioscopy is of paramount importance. You should repeat regularly, repeat post-PI, and repeat if in doubt without any ego. Treatment is, first line in primary glaucoma is laser PI. You don't laser all PACS, but with family history, poor follow-up, fellow eye of PAC requiring routine dilatation, our patient has gonio progression, or a patient is one-eyed. All PACS plus OHT, PAC and PACG except the ones with total PAS who may not benefit. Post-PI, 59% still have persistent ITC on UBM, so we cannot forget post-PI gonioscopy and can't assume angle opening. This is something we should remember. Medical management, associated ocular hypertension can be managed by all the medications which we use for open angle glaucoma, but don't forget the poor pilocarpine. In some people who tolerate it well, it does well in cases of thicker iris and in plateau iris configuration. So those candidates who don't have any contraindication, you can use pilocarpine also. And in acute attack, definitely have hyperosmotics. Paracentesis, the role of which is now heightened after the knowledge of ganglion cell loss in acute pressure elevation. And iridoplasty, PI as per appropriate, and medical management with or without trabeculectomy depending upon the decay of the intraocular pressure. Laser iridoplasty is something that we should know. In those willing or have side effects of pilocarpine, iridoplasty can be considered in cases of plateau iris or thick peripheral iris rolls. And simple procedure, energy titration and effect on pupil to be taken into account. It should be told to the patient in no uncertain terms, can distort the pupil to some extent. And you repeat the gonio post-PI and post-IP and reassess on the cases. Again, don't assume angle opening. Surgical management with concomitant cataract. Early glaucoma with good IOP control, you can do cataract alone. It will do well for pressure control. Moderate glaucoma with IOP within targets, again cataract alone. Advanced glaucoma, trabeculectomy alone or phaco trap depends on the skill expertise of the individual surgeon. Phaco done later after trabeculectomy can lead to filtration failure, so that is to be remembered. And it can be also combined if poor follow-up is expected. Trab alone can be done in uncontrolled glaucoma with advanced glaucoma. Target IOP is not achieved by medications or allergic to drugs. Counsel the patient well, use pre-op hyperosmotics, releasable suture is the norm. Watch for aqueous misdirection in such cases without fail. Drainage implants have a role in secondary angle closure like neovascular glaucomas, where you can put the tube in the ciliary sulcus, and they do well. Such patients with active neovascularization and suboptimal laser definitely will do better with drainage implants as compared to trabeculectomy. Eagle study and role of goniosinoculitis is debatable. Eagle study has its own limitations. To consider early lens extraction in all cases of angle closure, not recommended because there is not enough evidence and too many data gaps. Goniosinoculitis on date has not demonstrated significant clinical benefit to be considered the standard of care. So take-home message is always come to a complete diagnosis, classify angle closure disease according to ISGO classification. Remember, it's often misdiagnosed. Gonioscopy and gonioscopy is important. No ego, when in doubt, repeat gonioscopy. Use UBM ASOCT in appropriate situations. Laser PI is the cornerstone of management. Do not forget poor pilocarpine in ideal cases. And trabeculectomy with releasable sutures is a safer option with an eye for aqueous misdirection. Thank you so much.
Thank you, Dr. Sachin. Very nicely covered in such a short time. Can I have one quick comment from Dr. Sirisha on this? because of paucity of time, I'll request just
Yeah.
one comment from each of the panelists.
Yeah, I think Sachin, you've done a wonderful job, covered as much as possible, and I don't have anything additional to add. Maybe one point is in the presence of excess vault of the lens. That is one other mechanism which we are seeing these days. So early cataract itself, we would possibly
Yes.
be pushed towards doing a cataract extraction. Not, of course, not a clear lens study, but so although you don't take home the clear lens extraction from the Eagle study, but definitely an early cataract would be an option to
Lens
remove
vault.
in these cases, and that will be helpful. Thank you. It's available from today. It's available from today.
That's great.
We'll have to do something for Mumbai then.
No, 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 it's available. So in fact, we were getting it from Maharashtra.
Okay.
So what we started doing is pilocarpine carpinol that is available as ampules. So that is 0.5% carpinol, which is preservative free. So open up 2 or 3 bottles of that and put it in a preservative, whatever the tear lubricant bottle in a sterile way, and let the patient, because we first used it for our PI patients, because when we ran out, we used it as a pre-eye measure, and we found that the pupil constricted, we were able to do a PI. Only then we started dispensing it. This is in desperate situations, but obviously you can't have a label. 3 or 4 ampules, 5 ml, because each one is 1 ml.
1
so you
ml,
can
so
add
3
3
ml
or 4 ampules. No, nothing. It's only 0.5%.
Heat itself is less than what we have.
Yeah, it's only 0.5.
It's 0.5%.
But it's working because we checked it. We checked it for PI patients, it worked, and that's how we started giving it in desperate situations.